Yeah, sorry, I had to stop because, like I said, I have to stop before 10 minutes because YouTube is a stupid uploading thingy. Yeah, so we were talking about esophageal dysphagia and we divided into neuromuscular versus obstructive causes. Obstructive causes could be intrinsic, that means in the lumen or in the wall, or extrinsic, outside the wall. Intrinsic structural lesions will include tumors like esophageal cancer. Sometimes you get rare tumors which are benign, like leiomyoma of the esophagus, basically like fibroids in the esophagus instead. But these are rare. Strictures is quite common as well, and the most common kind of a stricture will be like a peptic stricture or medications induced stricture, like a pill esophagitis. Sometimes you have to ask in the history whether they had history of radiation or chemical ingestion, like maybe they try to commit suicide last time by drinking hydrochloric or sulfuric acid. These can cause strictures as well. Radiation, if they have like a history of head and neck cancer and they went for radiotherapy. The other things like Schatzki's rings and esophageal webs, these things are like not really important. The important thing about esophageal webs is that it forms part of this cool thing that you can maybe, I don't know, talk about for a distinction viva called Plummer-Vinson syndrome, which is the triad of esophageal webs, iron deficiency anemia, and atrophic glossitis. The importance of esophageal web is not so much the dysphagia, but the importance is actually that they get problems with, they get the increased chance of squamous cell cancer in the next 10 years. Esophageal rings, no increased chance of cancer, but it can present as an acute dysphagia that needs emergency endoscopic therapy to remove the bolus of food that got stuck, and it's called a steakhouse syndrome, just for those who like to have fun. Foreign bodies, maybe more common in kids. Extrinsic structural lesions, don't forget masses in the mediastinum, which can be of vascular or non-vascular origin. Of vascular origin, you can divide into whether it's aorta or an atrial mass. Aorta usually is a congenital anomaly, but don't forget acquired anomalies that cause dysphagia, such as maybe a huge thoracic aortic aneurysm from Marfan's or from, say, syphilis. Left atrium usually enlarged due to mitral valve disease. Mediastinal masses, so maybe you could have a huge thyroid or a lymphadenopathy pressing on it, maybe a lymphadenopathy like a huge thymus gland from a Hodgkin's lymphoma, which usually presents as an axial mass rather than a peripheral mass. Okay, so now we're going to talk about the two different kinds of dysphagia and their pathogenesis. Oropharyngeal dysphagia, as you can imagine, arises from disorders that anywhere from the mouth to the upper esophageal sphincter, whereas esophageal dysphagia arises from disorders that from the body or from the upper esophageal sphincter downwards. So it's like, don't forget what's important here is that the cardia of the stomach can cause esophageal sphincter esophageal dysphagia as well. So like if you have, say, adenocarcinoma of the stomach at the cardia, it can cause an esophageal dysphagia instead of the classic symptoms, say, of early satiety, upper GI bleed presenting as a melena. It can just present as a esophageal dysphagia. That is why endoscopy is so important to evaluate dysphagia. So like I said, the causes broadly divided into neuromuscular versus mechanical. You can just have a look here. I won't go through this since we've mentioned some things about this already. What is the difference in their presentation? Well, for oropharyngeal dysphagia, as you can see, I've highlighted in red here the main thing in oropharyngeal dysphagia that helps you pick it up is that it's the difficulty on initiating swallowing, as opposed to esophageal dysphagia where the problem occurs several seconds after they swallow. They find that the food gets stuck. In oropharyngeal dysphagia, they will point to the cervical region when asked to describe where the food is stuck, whilst in esophageal dysphagia, they will point to the suprasternal or retrosternal region. Oropharyngeal dysphagia can present with combinations of oral or pharyngeal dysfunction. And oral dysfunction will be indicated by them drooling, having difficulty speaking, like dysarthria, and food spilling out of their mouth. In pharyngeal dysphagia, the patients will regurgitate food through their nose, postnasal regurgitation, and have coughing and choking. They can have frequent lung infections as well, which can actually also happen in esophageal dysphagia, but that happens late when either the obstruction gets like really severe or a malignant tracheoesophageal fistula results. I'll talk about that later. Note that for all kinds of dysphagia, and especially for esophageal dysphagia, where the patient points to is not usually where the site of obstruction is. Lastly, we'll talk about functional dysphagia. Functional dysphagia is a diagnosis of exclusion. Patient must have undergone a complete diagnostic evaluation before you can diagnose it, and you must have not found anything wrong with the esophagus. Okay? What are diagnostic criteria? This is from the Rome 3 criteria. I think those guys are the guys who brought you the criteria for IBS as diagnosis as well. Making our lives easy as doctors and maybe hard as medical students. So they came up with these like rather difficult to remember criteria. So I've bolded the 2 important points. Basically, it must be at least 12 weeks, and it must be in the absence of basically nothing wrong. Okay, absence of GERD and motility. Okay, now that we've spoke quite a fair bit about the causes and classification, I'd like to go through how I would approach it clinically. I'm sure there's always room for improvement, and if you guys want to suggest anything, please feel free to comment on my the comments So as usual, we divide into history, physical, investigations, and this is nice part. Up to date, like I said, there are 2 really good algorithms which I'll share with you. So right up, I'm sharing with you this algorithm here. Okay. As you can see, when a patient comes in with dysphagia, the first thing that you need to do actually, which they didn't write here, is to exclude other things that could go together with dysphagia or be mistaken as dysphagia. These 2 symptoms are odynophagia, which is pain on swallowing, and globus sensation, which is a sense of a lump in the throat. Okay, so once you exclude these 2 things, then you can get down to your history proper. Like I said, the first question to ask is, when does the food get stuck? When it start, or or seconds after a swallow. If it's at the start, then it's oropharyngeal. If it's seconds after, it's esophageal. The next important point is whether it's difficulty with solids and or liquids, or just solids alone. If it's solids alone, it's mechanical obstruction. If it's solids and or liquids, it's a motor dysfunction, like a neuromuscular problem. If it's mechanical dysfunction, of course you think it's like heart cancer until proven otherwise. That's why you got to ask after it's mechanical dysfunction whether it was an intermittent problem or it's getting progressive. Because remember, rapidly progressive dysphagia is classic of esophageal cancer. If it's intermittent, then it's an esophageal ring, and that's like not so much to worry about. But that being said, they should still be scoped. If it's difficulty with solids and or liquids, and then it's like it's probably a motor disorder. And if it's progressive, then generally the diagnoses are worse. It's either scleroderma or achalasia. As you know, none of these 2 things are great conditions to have. Scleroderma because of the systemic condition manifestations, and achalasia because the conservative therapy isn't really going to help very much. They probably will need surgery. Chronic heartburn is associated with scleroderma, whereas achalasia, you're not going to get heartburn, right? Because the lower esophageal sphincter is tight, so obviously they don't get heartburn. Intermittent symptoms is more classic of motility disorder, like diffuse esophageal spasm and the like. Those are need manometry to diagnose, so I won't go through in great detail.